So for our call for papers, we got a really strong group of, we selected down to 6 very strong papers that we will, after peer review, put together for a special issue next year. And the 2 we have presented here today, Santiago unfortunately is not able to come today. I just heard that he's ill and not able to make the trip, but Anna Progovac, is that correct?
Yeah, it's Anna Progovac.
Progovac, okay. So fortunately, she's made the trip and is healthy. So we're glad to have her here. So you'll see that her work is looking, and I'm really pleased to include this in the complement of topics that we have because it addresses the issue of gender minorities, right? So thus helping us to be more inclusive of this definition. But also, if you think about gender as, a lot of times in public policy studies, we think of it just as a control variable. But I think the point that we have, I also direct a Gender and Policy Center at the Schar School of Policy and Government at George Mason. And I founded that initiative because I feel that there are so often it's not a control variable, right? Women and gender minorities are underrepresented in positions of power and public authority and overrepresented on those variables that we see as public policy bads, right? So proneness to violence, attributes of ill health, lack of access to education. I mean, globally we see that unfortunately there is overrepresentation in a lot of areas where we don't want to see it, and underrepresentation in positions of authority that could potentially mitigate these problems. So that's overarchingly where I'm coming from, both in my work at the Schar School and also in my work at the Journal. And so I'm happy to be in dialogue with you, and I'm pleased that you're here, and I'll just pass to Emma. Thank you.
I do want to say, if anyone was coming for the other talk and wants to duck out to a different talk, I won't be offended, so please.
There's usually some fluidity.
Yeah, no, I figure people are coming in and out, but let's see, where's it good? I am very accident prone, so I will remove that.
Keep the space clear.
Yeah, okay, and I guess we don't have to worry too much about time, so okay. So hi, I'm Anna Progovac. Thank you all for being here today. Feel free to, I think, interrupt with questions since we have time. I prepared for about 20 minutes. So I'm actually talking today about research that comes out of my health system in Cambridge, Massachusetts. So I'm at Harvard academically, and then I sit at Department of Psychiatry in Cambridge. I'm not a clinician, I'm a health services researcher, so I'm not a doctor. Well, I'm not that kind of doctor. But we've been doing a portfolio of work around transgender, non-binary, non-fluid populations. Yes. Yes. We've been doing a lot of work the last few years in our lab around transgender populations, non-binary, gender fluid populations, and particularly mental health outcomes. So this work is a piece of that where we're trying to understand how exposure to violence, being a victim of violence, is related to suicide attempt, which is a big problem for gender minority populations in the US and elsewhere. And I wanted to start by saying, like I said, this comes from a broader portfolio of work. We had a lot of help in a lot of different ways. One of my co-authors, Maria Jose Sanchez, is here. She helped put together, did a lot of the chart review for this, which I'll explain. So we wouldn't have this data without her. And we also really, especially since I don't identify as gender minority, it was very important to me to bring in voices of people who do, from advocacy world, from just community members. So we've, from the start, had a very community partnered approach. We've presented some of this work in community forums and asked people to reflect and tell us what they thought about just the numbers that we're seeing and kind of the relationships that we're trying to understand. So I have to acknowledge that lots of people helped with this. This is not like a one-person job. So thank you to everyone before I get started. I don't have any conflicts of interest. Some of this work was grant supported, but just through like a Harvard grant and some NIH money. So just to start, I think the language around what it means to be transgender or non-binary changes a lot, and the research language is different than the language used in the community. So when I say gender minority, I'm referring to, it's sort of like an umbrella term of anyone whose gender identity is actually different from the sex they were assigned at birth, or essentially how culture expects them, society expects them to identify based on physical characteristics at birth. So I will use that to mean transgender, non-binary, gender fluid, sort of an umbrella term. I don't mean to erase any of those individual identities within that, but it's what the National Institutes of Health now is using as kind of a separate term, and to distinguish from sexual minority populations. So none of what I'm talking about today will have anything to do with sexual orientation specifically. We don't have data on that aspect of people's identities in our data set here. And I may use the term cisgender. If I say that, it just means somebody who doesn't identify as transgender, non-binary, gender fluid. Yeah, so I think that's that. I always want to start with that because people use a lot of different terminology. Can you still hear me okay in the back? Am I projecting? Okay. So we got into this work a few years ago. Pretty new in my research career, so that's part of it. But there is this, we're sort of at a bit of a cultural inflection point, I think, about awareness of the fact that there are trans people and non-binary and gender fluid people out there among us, with us. Some of them are us, and there are more sort of public policies, public awareness. In the US, we've had a lot of these discussions around access to bathrooms, and even here today, you'll notice that there are different bathroom signs up that say, this is a sign that actually says what's in the bathroom as opposed to who should be in the bathroom, which is very helpful. So on the left is just, to give you a sense, Google searches for the word transgender in the United States over the last 10 years or so, or I think this one stops in 2015, so 15 years, just going up over time quite rapidly, and then you'll see some blips where there are a lot more searches at once, and those will be like a new policy gets introduced, or the initiation of this whole bathroom debate. So people are becoming more aware of what types of challenges people are facing, and sort of new debates that weren't as out in the open before, which has been, I think, both good in a lot of ways, and also put people who are gender minority sort of in a new spotlight, and they're being paid more attention to, which sometimes is good and sometimes is, I think, a lot to take on. And the other little graph here, just to set the stage, is the different types of federal legislations related to non-discrimination by gender identity that have been, since 2007, which is actually the first time such policies were introduced in the US, that have been increasing over time. The yellow, which is probably a little bit hard to see, is any sort of non-discrimination policies. And then the green down below, since I'm a health researcher, those are specifically health focused. And there have been more recently, so that graph stops in 2015. But again, just to give you a sense that before 2007, there were 0, and as the years have gone by, I think at the peak there was, in 2013, there were 20 federal measures introduced. So also for this summit that's focused on policy, this is a new issue, I'll say, for policymakers to be taking such, paying so much attention to, and needing to understand what are the risks people are facing, what kinds of things do we need to focus on, and what sort of protections do we need to make sure that we have in place. And so I won't get into too many policy-specific issues today, but there are people doing great work around like what happens when we change insurance policies or non-discrimination policies, and how do we think about how that affects people's well-being. What we do know, and this is mostly based on US research, but a lot of these same patterns are happening internationally. People who identify as gender minority face a lot more burden socially than many of us who don't. A lot of this comes from discrimination, comes from marginalization, and it can come from sort of even targeted violence, which is part of why we were trying to understand this relationship in our local data. So these numbers vary depending on what kind of research methods you use, and it's very hard to find huge studies, like national studies that actually measure gender identity. And so what we know from survey data that tries to aggregate these types of studies is that on sort of estimating, we're seeing probably around 4 times higher rates of extreme poverty, so very low income among gender minorities in the US. Eating disorders is a big problem for some people, especially when, so eating disorders are often related to issues of body dysmorphia and presentation and identity of self. And that also, so I'm in the Department of Psychiatry, so there's a lot of psychiatrists who are working with eating disorder specialists trying to understand what's the overlap between, you know, issues around gender identity, body dysmorphia, and how that plays out potentially as eating disorders too. When people are losing jobs because they come out as trans, or when they're losing supportive family or friends early on in their lives, there are these sort of cascading social implications. So people may become homeless early on or later on when they lose a job and they can't pay rent. They obviously lose jobs in a lot of situations. That's starting to get better. There were some recent policy debates around non-discrimination in employment, which is related to this issue. And so what ends up happening as a result of all of this, all these stressors, which are sometimes grouped together and called sort of gender minority stressors, because they're a group of stressors that you experience because you are gender minority, personally as someone who's worried about coming out, and then after you come out, what happens when people react to that. A lot of these have contributed to what we see as much higher rates of things like depression and anxiety, and as I'll show on the next slide, really high rates of suicide attempt. So it's a really big problem within this community. We also see that when people do try to get help, when they come in to health systems, there's also a big gap there about being able to meet people's needs. So people report being denied health care because they identify as trans or non-binary. And maybe much more often, there's just a lack of understanding by the health systems, both on the part of individuals, so people at the front desk, but even doctors who should be trained kind of in how to provide the most appropriate care for everyone. They often don't have training around trans issues, around gender identity. And then system-wide, so we see a lot of this. You may have a doctor who knows exactly what to do, but maybe all your systems don't line up so that when they need to make a referral, the person on the other end has the same understanding, and it translates into the electronic health record where things are marked clearly so everyone knows what's going on. So it's challenging because all of our systems have also been set up for male-female. Male-female gender markers, male-female lab averages, male-female cancer screenings, everything is set up that way. So it takes a lot to reorganize things, and that is sort of needed for people to actually feel that care is organized for them from front to end as they go through. And for us, and I think for me, one of the big motivations to get into this work was seeing that there's a huge gap in research knowledge around what are risk factors for this population, what do we need to do. A lot of that is because, again, a lot of our research databases and health databases on which we do research have been set up male-female, male-female, maybe increasingly in recent years, what's your sexual orientation, but very few of our databases have anything about gender identity. So it's been very hard to get systematic data around these issues. And so that's kind of why we're here today. So a really concerning risk in this population is a really high risk of suicide attempt. And suicide attempt has been a bigger problem recently in the US as well. It's a growing issue. Even in the last year, I've known people who have lost friends to suicide. And a lot of times it's like, people just were like, where did this come from? This seems like totally out of the blue. And for people who are trans or non-binary, just the much higher rates of suicide attempts. So in synthesis of peer-reviewed literature and also some of the quote-unquote gray literature, it appears that over half of people who identified as transgender had ever thought about committing suicide, and about a third had actually attempted to commit suicide, which is just way higher than the rates that we see in the general population. And keep in mind, even those rates have been increasing in recent years, at least in the US. I don't know the international literature as much. So for example, in the general population, they think the lifetime rate of suicide attempt is less than 5% versus, for example, 30%. So what the other thing that's true is that what we know about these rates depends on how you've done the study, right? If you have a survey and you ask people, if you ask young people, if you ask older people. So there's a lot of variability, and so I think any amount of additional research that we can find that can understand in different contexts for different populations what are sort of the suicide attempt rates and what's maybe driving some of those rates, I think is really helpful, because we know, our providers in our system, they have a lot of people coming in with suicidal ideation, a lot of people who end up in the inpatient unit, the psychiatric inpatient unit, and they're really trying to understand for everyone, and especially for people from gender minority populations for whom they may not have a lot of experience seeing lots of patients who are trans, just because as a percent of the population, it's much fewer people. So they're trying to understand what's driving a lot of this, what can we do to help, when should we be very concerned, when can we try to work with their family and feel confident that if we discharge them, they may be okay. And so as providers in a system, although I'm not a provider, I hear a lot of their stories, there's just a lot of desire, obviously, to help people as much as possible and to understand what kind of risks we can sort of mitigate. So today I'm specifically talking about research from our health system, and I'm focusing on, I know it says ideation here too, but actually this talk is specifically on suicide attempt and violence victimization, both just as captured in electronic health records, and I'll explain how we did that. We're trying to compare what we're seeing for gender minority populations in our health system with sort of everyone else, like the average other patients in the system, and trying to also understand, if we can, sort of how violence victimization is related to suicide attempt in the data that we see. And the reason that I'm sort of interested in that is not only because we know that both of these things are obviously really negative outcomes, which should be trying to reduce them both at all costs. But I think we hear this narrative that because there is so much targeting of people who are gender minorities specifically, whether it's bullying, discrimination, or actual targeting with violence, people are trying to understand, like, if we're going to do interventions, where should we start to invest our time? What should we be doing? And so I was curious, like, if we focused on reducing violence victimization or understanding how much that contributes to this higher baseline risk, how far would that kind of get us? That's kind of the frame that I have. And so there's going to be obviously a lot of limitations to our data to address this question, which I'll talk about, but that's sort of the question I had going in.
Can I just ask a clarifying question?
Yeah, definitely.
This assumes that the violent victimization is because of their gender identity, or?
So it doesn't.
Okay.
And I'll talk about that. So we can't pick that up in the data that we have. It would be really helpful, and so there are studies that look at, like, even if you were discriminated against in healthcare, specifically around gender identity, linking that specific type of discrimination to higher suicide attempt, which is really interesting. And so I would think that if we could answer that question that you just posed, it would be even more sort of on the nose for what we're trying to get at. And so our measure of violence victimization is broad. It's any type of, I'll show sort of the specific things, but it's like if you were abused, if you got in a fight and you were a victim of violence and you come in and you get that diagnosed in the health record, that's what we're picking up right now. So again, this type of work with health record data, that's secondary data analysis, has a lot of limitations based on what's coded in there. And so this type of thing is super helpful, I think, to do additional studies, additional qualitative work, additional survey data collection, but this is where we're starting from. Yeah, so thanks for that.
Real quick, adolescents included or just adults?
So we have a whole age range here. We didn't restrict to adults. Yeah. Any other? Yeah.
Did you measure people who are poor or homeless within your data collection, or was there a way for you to
So,
determine that?
so we're trying to add, and I'll get to what we have in here. Right now it's pretty simplistic, and we have a little time to hopefully add some more variables and do some more analysis, which we're working on. We can get at that to some extent. There, for example, we can figure out who has Medicaid insurance, which gets a little bit at income level. There are some more recent measures, like basically quote unquote diagnosis codes that people have been including that get a little bit more at like homelessness or unstable housing. And we started to look at that. I don't think it's very well documented. So we're seeing like way fewer instances of this than we know are in our health system. I will say the health system we're in, it's a safety net health system. They serve a lot of Medicaid patients. They serve a lot of homeless patients too. There's a lot more people in our health system who don't speak English as a first language than some of the like Mass General Hospital. So I'm at Cambridge Health Alliance. It was basically like it's the only like public hospital left in Massachusetts basically. So it's sort of like a public health system, you can think of it as. And we are trying to add some of those variables into these models moving forward to understand how much that contributes. But I will say that that's probably a big portion of people that we're including too. What's not clear to me is if the people that we found who are gender minority are necessarily represent. I think we might be finding like a more higher income group of gender minorities than is probably out there in the community. So that's one possibility. So let me say a little bit more about how we built our cohort, because I think it'll be a little easier to understand sort of what we're working with. So as I said before, so one challenge with studying this type of question is that we often don't have self-report of gender identity in the health record. It's changing slowly. Like they now have a field in a lot of health records, including ours, where you can specify gender identity, but it's not universally asked yet. So some clinics use it, some doctors use it, so some patients have that recorded, but it's not a reliable marker. So what we did is we used about 10 years of historical data, so from 2008 to 2017, and we actually used two methods to try to identify people sort of retrospectively. So one method is using a type of diagnosis code that's usually given to people if they are seeking some type of care related to gender affirmation. So usually if you get hormones or some type of surgery, there needs to be like a diagnosis code to justify the provider issuing hormones, for example. So used to be called gender identity disorder. That's still how it's called in the ICD, the International Classification of Diseases. Thanks, doctor. And now, like in the DSM, which is like the mental health kind of handbook, they call it gender dysphoria. It's trying to move away from this kind of stigmatizing language. And actually, the World Health Organization is even again changing the definition to gender incongruence. I think is coming in the next iteration. But that's essentially a measure. Essentially, it's trying to get at, does somebody experience distress from the fact that their gender identity doesn't match with their sex assigned at birth? And so that's essentially what that diagnosis code is supposed to capture. There's a lot of issues with where that came from. Lots of people think it's very stigmatizing. But right now, it's one of the ways that doctors help people get care that they need, because they sort of need to, oftentimes for insurance coverage, they need to use this type of diagnosis code. So we're using it to find people in our data who, although we haven't been able to ask them, we are very confident that they're likely in this spectrum of people who are gender fluid, non-binary, or transgender. And we've done this before in insurance claims data, so we've used Medicare claims to study this population. Other people actually from the Medicare program first sort of developed this method and sort of validated it. So it's not perfect, but it starts to get at a group that we at least know with pretty good confidence is the group that we're looking for. To build on that, because we're in electronic health records, we also use data from the clinical notes. So when you go into your doctor and they type up a note at the end of the visit that other doctors can see, there's text in there, there's free text that they type. And so other groups have used this to also identify people in health record data around, so it's, I think I have a slide that has some of the examples, but you start with really simple things like you search for the word transgender, you search for terms like gender identity, and there's a whole list of them that we looked at, and then you basically do like chart review. You look and see what's, when you pick up a person, you pick up that note, you can read it and see if from that note and some other notes you can start to understand, okay, is that talking about this person? This is what Maria was doing. Is that talking about their aunt or some other thing entirely? Sometimes you get funny things that you don't realize are like medical acronyms or something, like when we searched MTF, which is sometimes male to female acronym. You also get things like metformin. So there's some obviously brain power that goes behind this, but that's a way to really augment beyond just the people who are getting certain types of care and try to get more at people who are talking to their doctors about these issues or who are coming in with distress related to being trans, but they don't have hormone, so there's a lot of ways that people might express their gender identity that could have nothing to do with hormones or surgery. And so we hope we're picking up more people and a broader variety of experiences when we do this kind of keyword search. But obviously, again, it's limited, and it means somebody would have to, at some point, have gone in to get medical care, and at some point, talk to their doctor, and at some point, the doctor or somebody would have had to write that down. At the same time, we do find a lot of people this way. And then we basically just have kind of a comparison population, which is just supposed to give us a sense of what's going on in the rest of the patients. It's not supposed to be, some kind of control group, but it's basically let's get a frame. What's the average for the rest of the population at CHA? So I'm just going to start by showing the rates, the differences in violence and suicide attempt, and then we're going to try to understand some of the relationship between those variables. And so right now it's a pretty straightforward analysis, but I think helping us start to understand what's going on. So I spoke about these, and I put these in quotations because they're actually like pretty offensive diagnosis code terms, but these are the terms that were in the coding system until 2015. They're still in the current version, which is ICD-10, and hopefully they're changing soon, but the ICD-9 changes a lot slower than even like the DSM systems. And there's lots of things you can read about how these terms are problematic. But I just don't have time to talk about that a lot. So these are some of the terms that we use. So you can see like some of the most like high yield search terms. The ones that are starred came from prior research by a group out by the Kaiser Permanente group, which is like a big integrated health system, and they have a lot of research capacity. So you can't read these, but some of the sort of most high yield terms were transgender, gender identity, female to male, male to female, gender dysphoria. Then there's some things like gender reassignment, gender fluid. We got some suggestions from our community group and community members too. So we searched for things like two-spirit, just like a Native American term that often comes up. We didn't actually find anyone in our system that way, but we tried to think about things that we might normally miss. And I think that speaks to more like when you talk about people coming from different cultures, different language backgrounds, how do people talk about this in their own way? I think that's a big limitation of some of this stuff at this point, that we don't necessarily have like a full lexicon here. But we've ended up finding, starting with like 1,500 people in this search, and ended up getting down to a little over 600. And then we combined that with the people that we found using the diagnosis code method. And this is just the basic kind of simple demographics of the two groups. So on the right, you have the gender minority population. On the left is the other patients in our health system. And so, and actually, I think some of these numbers are flipped around. Sorry, this first number, I just was inputting this last night. So So actually the gender minority group is younger, so their average age is 25, whereas the rest of CHA patients that we identified were closer to 32. I think the rest of these are the right numbers, sorry about that. So the other difference was that the gender minority group that we identified were more likely to be white and more likely to speak English at home than the rest of the patients at Cambridge Health Alliance. Like most of the research in the national surveys show that on average, gender minority folks do have a little bit of a lower than average income, more likely to be on Medicaid. A lot of that is because of this issue related to discrimination and unemployment. And a lot of like early adverse experiences disconnected with family and then having to kind of make your way on your own. Lots of people also very successful. So, but on average, we do see a little bit of a difference. And so we're not sure, it might be that the people that we pick up in our health system are a little bit better off than people who are actually out in the community not coming in and getting care. So that's one thing to keep in mind. Like we might already be looking at a little bit of a better off kind of cohort. Is that what I wanted to say? Yeah, we didn't see in our data right now, we don't see a huge difference in the percent of people who are on public insurance or not. But that's different than sort of what we see in some of the other data sets too. So again, hopefully as we get better at identifying more people, we'll see like a broader range of people too. So the suicide attempt outcome that we looked at, again, we're limited to what's available in the health record. So we used diagnosis codes that a doctor would assign to somebody if they came in and they said, yeah, you had a suicide attempt, I'm going to code it that way. But we also know that suicide attempt is often underreported generally, and for someone to come in and then have a doctor examine them and then have them assign that code, there's a lot of steps there. So there are researchers who have looked at other diagnostic categories that are essentially highly probable to indicate a suicide attempt. So we included those as well. So it's a little bit probabilistic, but hopefully we're picking up a few more actual suicide attempts in that range of codes. And so they did a lot of validation. They did that with electronic health records as well. We have a very similar strategy with the violence victimization outcome. So there are specific codes that capture this if you come in and a doctor assigns you a diagnosis of things like abuse, neglect, being a victim of partner abuse, and then things related to maltreatment, neglect. They also, however, have done research around the same type of thing. Like there are codes related to getting injured in a fight, being poisoned, or being injured in an assault that obviously do capture like violence victimization. And in their study, they were also, they were specifically looking at sort of partner violence and saying that a lot of those codes also often are related to partner violence. But we've used this broader definition to say someone was hurt, it was for an external reason, and we're trying to link that to understand how much that overlaps with suicide attempt. So just to kind of cut to the simple chase, so the green is the green are the rates for gender minority, the gender minority population, and the yellow is the rest of CHA patients. So basically this line is about 6% prevalence. So about 6% of the time in our gender minority cohort, people had actually had a documented suicide attempt. It's actually pretty high since it's electronic health record data. So there are all these steps to having to actually go in, get a doctor to give you a code. We know it's probably much higher in the community level. But we also saw similar rates of violence victimization. And then you'll just notice that the non-gender minority cohort, it's like about 2 to 3 times lower rates of both. So it's more like 1.5 to 2% of the time people have a suicide attempt or a violence victimization. So it's the ratio is a little bit closer in this group than some of the sort of national studies that take into account the lifetime self-reports. But again, this isn't self-report, this is just what we see in our data. And we still see these big differences.
What was the self-report rate?
So if you looked at the self-report for lifetime attempt, it's 30%. Well, that number actually comes from a lot of different studies. So they're estimating it about 30% for gender minorities versus 4.6% for the general population for an actual attempt. So we're seeing 6%. I think also keep in mind this is not lifetime. This is a window in time that we picked up people, and so it's like a few years of their life that they came in. And also, it could be that someone has an attempt that doesn't end up getting coded in our health system as such. They could have not come in for healthcare. It's possible that they actually died in the course of the attempt and never made it to healthcare, and it was never documented. So what we're seeing is sort of part of the whole number of attempts. So that's important to keep in mind why that number is a lot lower. So just to kind of start to get at what we're trying to think about, I think of these questions as helpful for understanding, again, like what types of policies should we be targeting. And so just to set up this simple concept of like, do we think that violence victimization is potentially a mediator between the fact that someone is a gender minority and having a higher rate of suicide attempt? If it were a mediator, that would mean we think most of the risk of suicide attempt, or a lot of it, comes through the fact that people experience violence. And if that were true, we should spend a lot more of our energy, if we wanted to reduce risk for this group, focusing on removing that risk of violence victimization, whatever that might mean. On the other hand, if it moderates the relationship, depending on what we see in that moderation relationship, that could imply other types of interventions potentially, depending on whether it goes up or down. So I'm just trying to set up the idea that understanding to what extent violence victimization explains suicide attempt in our data can be useful for thinking about, I think, how much that alone should be something that we might want to focus on. Bless you. Does that make sense, just like setting up that framework? Okay. So, so this is I'm just going to walk through the sort of mediation, moderation results, and then I think a figure that actually helps me think about the findings. So the first take home is we didn't actually find any mediation effect that was significant. So that's this number showing, and this is just, it's essentially like logistic regression. It's age adjusted, but we haven't put in any other covariates yet. So we're just trying to understand if you think of violence victimization on that pathway, is that significantly like detracting from that arrow between being a gender minority and having a suicide attempt. And the take home is it doesn't. So it's not explaining what we see as that higher rate for gender minorities. And part of why, I think we'll see in a second, but now for the moderation analysis, what we can see a little bit more clearly here, these are like the independent contributions of gender minority status and violence by itself. So each of these, both being a gender minority and if you have experienced violence, very much, so 4 and 5 times more, these are the odds ratios, increase your risk of suicide attempt. They're each independent contributors. And we did see an interaction between being a gender minority and having a violence victimization. Interestingly, it's sort of in the opposite direction that I expected. And this picture, I think, explains what's going on. And so on the left, we have gender minority status, and on the right, this is the gender minority population. On the right are the rest of the patients in yellow. So if you have violence, you're in these left 2 bars. And if you don't, you're in sort of the right 2 bars. And so what you can actually see is the average rate of suicide attempt is very high compared in the gender minority group compared to the non-gender minority group. But if you have violence, if you're a gender minority person and you have a violence victimization, this difference that violence contributes is actually smaller in the gender minority group than in the rest of the population. And essentially the reason why is because people who are gender minority actually have a much higher baseline rate of suicide attempt even before they experience violence victimization. So someone who's a gender minority and doesn't have a reported violence victimization actually has very similar rates to somebody in the general population who experiences that really traumatic event. And then if you add violence into somebody's experience as a gender minority person, their rate does go up. They actually have the highest rate of any group here, obviously, but it's sort of a marginally smaller difference because their baseline rate is already so high. So that's actually picking up that significant interaction term, and if you don't look at what the results look like, it's a little confusing, but when you look at what the results show, it does show that, you know, if you get rid of violence, it's not going to bring this baseline rate down all the way to here. So there's obviously a lot more that we have to do for even the people who don't experience violence. But violence by itself is a huge factor, and it does contribute to the increased rate in gender minorities. And that's essentially, and I know I took more time just because we didn't have to rush, but that's essentially where we're at with this analysis so far is, you know, we know violence is an independent risk factor. We know it's higher in gender minority patients. It's a problem for everyone. It should be addressed. In our data, it doesn't appear that addressing that would really get at a big part of the baseline risk in gender minority patients, which is maybe not surprising, but I think trying to understand and pull apart what contribution different risk factors have, I think is important for figuring out how you allocate resources toward interventions. I think one thing that it's not possible for us to pick up in this data that I would be really interested in is how knowledge of violence in the community and other people's experiences of violence does contribute to your own suicide risk, because especially in Cambridge and Boston, I know the community is pretty well connected. So as soon as somebody experiences an attack, there are networks that share this within the trans community for good reason, so people are more aware of them, and at the same time, it must have a huge impact on people reading this and feeling threatened. So in our data, we're just capturing what's happened to one person and their own suicide attempt risk, but it may be possible that, you know, even if we're just talking about violence, which obviously isn't the only risk factor, but even this group that hasn't personally experienced violence, very likely that they know someone who has, and they may be more aware of it than this group, which is not like a very well-connected community necessarily at all. So that's just one thing to take away, just to say, like, the impact of violence, especially in a community that's already more connected, could have just like social network-wise a much bigger impact as well. And I think I talked through some of these limitations actually as we went through them. And I think just one that I want to say again, just to make sure I've said it enough, is there are going to be lots of instances of violence out in the community that don't get reported, both for people who are gender minority and people who are not gender minority. It may be true that in our cohort of people who are gender minority that that's even more likely, especially if people have had bad experiences with police or institutions or doctors. There's a lot of things that came up in our community forum when we were talking about this work around this distrust of systems. So our data are limited in what we can pick up in the health record, and that may have implications for, you know, the relationships that we're trying to understand. So, you know, take that with a grain of salt. We have the data we have. I think it's useful for trying to understand things, but it's, again, limited in that capacity. So I think just one take home for me is that we definitely need much more comprehensive approaches to reduce risk of suicide attempt in this group. You're not going to get all the way there just by trying to focus on violence alone, which is probably a no-brainer, but thinking about all the types of experiences people are having, and, you know, what is it in that sort of baseline group that hasn't experienced these traumatic events that are having such high rates, I think is going to be more useful than just assuming that people have had like the most extreme experiences and only those most extreme experiences contribute to the baseline risk. So that's all I have to say for now, and I'm more than happy to answer questions. Thank you all for sticking with me, especially because you're hoping to hear 2 talks.
I guess I'll just start off by saying thank you so much for doing this work. And just the other day, I attended a talk with somebody from the National Science Foundation, and her research was on unconscious bias in scientific publication.
Oh, yeah.
which was really interesting, but it raised the point that who gets to ask the questions and what questions are asked is so important.
Yeah.
And just so this work, even by asking the questions, and I know as academics we are obligated to talk about the limitations of our work, and I often feel like to the general public that can make it sound like we're equivocating or it undercuts the importance of our work, do you know what I mean?
Yeah.
But so there's gotta be the like academic humility to say like, yes, there are limitations, but then there needs to be sort of the public campaign to be like, the limitations, I don't think in the general public mind they understand the limitation, you know, the issue of limitations as much.
I see what you mean,
Yeah, a lot of times my policy
It's
students.
still worth doing. Like,
Yes,
yeah.
because they get to, my new policy students get to the end of a research article and they're like, well, that was not useful. And I'm like, no, that's not the point.
Yeah.
The point is that we're trying to, right, we're trying to be just really careful about how we craft our analyses. But anyway, which is all to say that we're in a time where the asking of this question is a tremendous acknowledgement of sort of a known but previously unacknowledged bad, and to me that's a great sign of hope and a great thing, so just that part I wanted to emphasize.
No, I was just talking to a friend who she's a professor. She was actually saying that she's really concerned about people's understanding of like evidence generally, because her students, when they read like observational studies that don't get as much into the limitations, they think it's true, and then when they read like really carefully done experimental work and has a lot of limitations, they actually question it a lot more. So it's your point of like, if you are super transparent about all the problems, people are like, well, that's obviously.
Which is the hallmark of a good study,
Yeah.
but which could undercut its utility in the public sphere. So, I mean, my answer to everything is we need more education, but I do think that understanding the simple basis of scientific inquiry would strengthen the public's ability to parse that.
Yeah, and I guess we gotta figure out how to communicate better as well as the other flip
Yeah.
side always. Yeah. Any questions about concerns? This is still, we're a few months out from submitting the full manuscript, so we're actually going back into our health records and trying to find a bigger cohort and trying to get at some of those sociodemographic factors if we can in the health record to the extent that we can pick them up. So any suggestions or thoughts would be very welcome at this point.
I want to ask you something.
Sure.
I wasn't in Boston. I moved recently to Baltimore, and I wasn't at the community forum. So I think, going back to the idea of integrating the community in potential solutions, I know that you presented these data to the community. How did they react to it? How was,
We didn't plan this, but
we did.
we're on the same page. So I put in a few of the slides from like the results of the forum. So this was already like over a year ago. We helped sort of frame the message to our advocate and community partners so that they could help us recruit people in the community who might want to come in and talk about really fun topics like suicide and violence. So it was kind of a heavy day, but I think we did a good job of like making it kind of just like a safe space to chat. It was more like a dinner. And I thought it was very important that I not talk most of the time, so I didn't. So I had Amelia Dunham, who you know. So Amelia's awesome. She's trans herself. She's working for the state for the Medicaid program. She was like our moderator for the night. And then we actually set up different tables where the sort of table leader for each table was either trans, or I think one of them was a woman who identified as a lesbian who's a doctor in our system. But we tried to make the research team sort of note takers at those tables and not really lead the conversations. And then we presented sort of some of basically just the percentages. We didn't kind of walk through, mediation, moderation stuff too much, but we were trying to understand the rates that we were finding, how people thought those reflected their experience, and also why they might not. And so some of the things that we heard were, like I said, fear of reporting being a big issue. So people said, first of all, they said these rates are way too low. Like one person said, every friend I have has attempted suicide, every friend who's trans, which just yeah, that is what makes me think of like when we look at these one-off, like your experience and your suicide attempts, how much are we missing the impact of your network and your friends and what you know is going on? But they said, a lot of people said to us, you know, I can't necessarily trust doctors. If I go into the emergency room and it's a doctor that I don't know, and I'm talking about feelings of suicide, they're going to send me to the hospital. I'm going to get sectioned, so they're going to put this hold on me in the ER where I can't leave, and if I leave, the police are going to come. I don't know if you all know how this works, but basically if the doctor decides you're a risk to yourself or others, then there's sort of like a legal trigger that now you can't leave the ER, and they're going to take you to the hospital. You're going to go through inpatient. So obviously for any of us, that would be a huge decision point about whether or not to actually disclose that you're thinking about suicide. If you're also really afraid of going into an inpatient unit because you don't know how the doctors there are going to treat you, you don't know what the bathroom situation is going to be, you don't know what the rooming situation is going to be. A lot of times people are confused about, should I put this person into a room with another person whose gender matches their gender presentation or the gender they were born with? What if that person has opinions and they're going to say something to this person? So actually policies around bed assignment are, I think, very confusing in a lot of places. I haven't gotten a clear answer from our system about what they are yet either. So there's a lot of fear, I think, that people talked about. And they were also asking for like other options aside from ER and inpatient. Like, is there some partial hospitalization that is trans friendly for me, so I know when I go there I'm going to be safe? And the short answer is, like, in systems like ours that are very strapped, I think trying to find the resources, like we don't even have very good partial hospitalization programs for especially young adults generally, and so you need to bring this type of thing up to the attention of the whole system, which is like one of the things that I've been lucky to be able to do, is present this to the system in a few different ways. Without this type of research, it's a bit laborious and takes some money and takes a team. You can't find this cohort of people and feed it back to the system and say, this is what your patients are experiencing. It's not just national survey data. It's not, you know, anonymous people in Oregon. This is like people from your local community. And it's been, people have been really responsive. Sorry, I guess I can look at this bigger. I think one of the other things that was interesting, which I think is super relevant for kind of like what bias do we as academicians or clinicians bring to our work. People said a lot of the kind of screeners that they get around mental health and suicide risk are, you know, they were saying, oh, I can recite, like one of them is the Kessler 6 is a famous one. They're like, I can recite that like it's my, you know, birthday, but it doesn't have any questions in there about anything to do with my transition, anything to do with how I'm doing now that I'm on hormones. Like none of it had to do with some of the things that were really important to them at the time. So that was another, like, we've heard that before too from other communities saying like, none of this is asking me anything about the trauma that I experienced out on the street. It's asking me like, can I sleep? But someone got shot in front of my house. So like, you're not really asking me the important things. And so that came up a lot. And then I think another, what was the last thing I was gonna say? Oh, I think another big thing, and I think this is something that in mental health systems we have to acknowledge a little bit more, is that if there's a mental health provider who is essentially like signing off to help with things like getting access to hormones or helping someone who's going to get a surgery, those people are actually in like gatekeeping positions for the person who's trying to access care. So you typically, and this is like, depends on the system a little bit, but typically you basically need a mental health provider to like sign off that you're okay before you can get hormones or surgery. And so it basically puts people in a position where if they kind of need hormones or surgery before they can feel okay, because now they can feel like they're in the right body or they're moving toward that, they're kind of stuck. So they may not want to acknowledge they're feeling suicidal right now or their anxiety is really out of control because they're worried that that's going to halt the care that they've been working toward with that person. So that's really challenging too. Again, if you don't trust your doctor, if you feel like they don't know you enough, like you may be put in an awkward spot about whether to be honest or not. So that came up a lot too. Like, I think one person said something like, yeah, this one, like, the only thing I was living for was to transition. So if there are roadblocks in the way of doing that, like, why am I living? So that was like, you can contribute to someone's suicide risk even by putting up roadblocks that people maybe at some point put up thinking this is for somebody's protection, to make sure that somebody who's not in the right state of mind doesn't make big decisions, that they, that do have, like, not necessarily, I mean, I guess you can, especially for surgery, I think that's especially where people worry about it. But, you want to make sure that this is the right decision, and trying to ensure that someone's in the right state of mind has been a big concern for a long time. I think we're moving away from that and realizing, like, this is not, it's not different than a lot of other things that people decide on. So, but mental health providers have been very much part of this pathway to transition for a long time. And so people need to realize, like, how, I think, sensitive and powerful that position is in people's lives. And so these are just some of the other quotes. Like, "That's too low" was something that came up a lot. And this also, so violence against trans individuals is at an all-time high. And we hear and see that a lot too. So there's more documenting of and like national awareness of especially trans women and trans women of color who've been murdered. And so I think people see this and walk around with it too, and trying to understand, obviously that's a very bad thing, and it's possibly getting worse because people are more aware, and so people who have biases and who want to commit violence, like, maybe they're more empowered because we're talking more about issues. But so it's really, I think when you talk to community members, they tell you a lot more than the sort of secondary data tells you, but trying to understand what to do with combining people's stories and sort of the rates that we see in the data is sort of what we're trying to do. So, yeah.
I would be interested also in knowing about suicide outcome,
Mm-hmm.
and also in a smaller community, if suicide outcome would then also lead others more likely to also choose suicide.
Yeah.
And we think about these things in education when students.
Yeah, I was going to say
like
this.
we had a fraternity member, and so again,
Yep.
how does that affect those smaller groups? It seems more powerful.
Yeah. Yeah, that's right. I mean, I think I first got interested in this work because there was a student in my high school who committed suicide, and nothing like that had ever happened for, as long as I can remember. But I do remember they brought in all kinds of counselors, and there was like a real concern that, there's going to be sort of copycat, or it's like a social phenomenon that this spreads as like a solution that people latch onto. So I agree. Like, I think the fact that this is clearly so prevalent within some fairly tightly, I'm not saying the whole trans community in Cambridge is connected, but there are support groups that people go to. There's other sort of groups and advocacy groups that people are connected to, which is great. And then at the same time, you do have much higher awareness of all the issues that other people are facing. So I do think that's a really good question. Like, how does just awareness of or knowledge of the outcomes of things change how people think about their own options? And yeah, I think thinking about how you support the community when there's sort of like a loss experienced, especially within a tightly knit, maybe higher risk community, is really important for that reason exactly. Yeah.
I just want to say, I think that there's a lot of implications for this, particularly in like institutional educational contexts. I'm from Reno, Nevada, and my mom is in charge of counseling and social work there for Washoe County, and they have one of the most progressive policies in the country for accepting and allowing transgender individuals to be supported and use whatever bathrooms are appropriate for them, that kind of thing. And if I remember correctly, one of the most compelling reasons was the suicide risk. Like, the reason for this unusually progressive policy is that they were connecting it all to mental health and suicide and saying, well, we're gonna, and with collaboration from trans advocates in the community, just saying, well, the mental health concerns and the suicide concerns trump everything else.
Yeah, yeah.
And we
That's
don't
right.
really care about all the controversies when we
Yeah.
compare these things.
I think that's right. If you show people how big the risk is, just like, look, people's lives are at stake, like we have to address this. And I you know, that's sort of what I got as reaction from I presented this to the Department of Psychiatry at CHA and at some other contexts with like people in like more management positions, and usually the question is like, well, what do we do? Like they want to address it. They want to know like what's the next step, and so they're doing a lot of things around bathrooms and stuff like that. And I think from a health system perspective, you have a much higher, you know, you've got to do a lot more because you're caring for people, and it's not just like, oh, I'm a mental health provider, I need to know. It's like, no, everyone in the health system is a person somebody who's trans or non-binary can encounter at a certain point in time. And so figuring out like end to end when someone comes into the system, what's their experience, I think is really important. And there's a committee that's now working on that at our system, and I think hopefully increasingly at other systems. But they are, you know, realizing there's a lot of different departments, and you know, it's like from signage on bathrooms to EHR to, you know, frontline staff, like just people on the phones, people in even like interpreter services. So we have interpreters on the committee, and they were saying when they see, like what they see on their screens is not actually the health record that everyone else sees. And we were saying like in some languages, the first thing you address someone with is already gendered. Like you're like Mr., you know, there's like a respect that you're supposed to address people with in a certain language, and the respectful pronoun is like already gendered. So they were like, we don't see any information about gender identity, and we might be, the first thing we say to someone who we can't even see might be already misgendering them. Like we need help too. So it's really interesting to see like how many different points in the system this becomes an issue. And I guess the heartening thing is that people are thinking about these things and bringing them up higher, you know, to more attention and trying to work together. But it does show just like how many ways everything is gendered, and you need to like think through almost every single pathway here. So I think that's a reason why it's been slow, because it's not like you can just change a sign and everything's fine. Like there's so many different things you have to change. But you know, you got to start somewhere. So hopefully, slowly but surely, we'll get there. But that's a great point. Yeah, thank you.
I think we're coming up to the end of the session, but thank you so much again for being
Yeah,
here,
thanks.
and thanks to all of you.